Welcome everyone to our second session. We have again two interesting papers with two discussants. Same rules as before, 20 minutes for presentation, 15 minutes for discussion and 10 minutes for questions. And our first presenter is Daniel Weagley from Georgia Tech.
All right, well, I'm delighted to be here and present this work. It's undergoing a major revision right now. We have some new results we're really looking forward to getting feedback on. Unfortunately, the discussant hasn't seen some of those results. We try to get a new version to her. I know. We have good excuses. Taylor had a baby, or his wife did in the past few months, and took a new job, and he's moving across the country right now. So he's got a lot going on, which has delayed us. Okay, so let me jump in here. The motivation for this paper broadly is similar to the motivation for this conference. COVID really disrupted nearly all parts of society, and it was really crippling for a lot of firms. They experienced plunging revenues, new and significant costs associated with testing for COVID, how they're going to handle remote work, things like that. And there's a lot of uncertainty about the severity, length, and consequences of the pandemic. How long was it going to last? What was the new normal going to be? And we're broadly interested in this question of how do these financial difficulties for firms translate to risk for non-financial stakeholders? And more specifically, what we're going to be interested in this paper is in how financial resources are related to the spread of COVID-19 in skilled nursing facilities. And we're going to broadly find that the facility's immediate financial resources do affect the likelihood of COVID-19 entering and spreading within a skilled nursing facility. So we find a higher likelihood of COVID entering and spreading in facilities with lower cash on hand at the onset of the pandemic, and those facilities that were more greatly exposed to the negative cash flow shocks that were a result of the pandemic. Okay, so the story we have in mind here is that if you had cash on hand, you had financial resources, you were better able to invest in sort of the risk mitigation necessary to protect your residents, your customers. Okay, you can buy the masks, the PPE required to keep them from getting COVID. We're also going to find that these facilities had higher rates of employee resident transmission. So facilities with lower cash and those with more adverse cash flow shocks. So that's broadly what we're going to find. Let me get into the details here. So nursing homes are not well studied in the finance arena. And really when we say nursing homes, we're talking about skilled nursing facilities. And there are about 2 million people in skilled nursing facilities in the United States. There's around 15,000 facilities. And the people that end up in these facilities are not healthy. A lot of people go to these facilities because they've had a major injury, they've undergone some surgery, and they need to go to these facilities to recover, or they've had a stroke. So they are a very fragile portion of our population. Over 84% of these residents are over 65 years of age. And due to the nature of their health, they need high-touch, in-person interaction with the employees of these facilities, mainly these skilled nurses. And so that's going to amplify the importance of risk mitigation measures. You can't stay 20 feet away from the residents. They need, hands-on care. And what makes this an especially important setting to study this question is that despite 2 million people being around 1% of the overall population, or a little less, about 40% of U.S. COVID deaths during 2020 were in these facilities. So it's a very vulnerable population. People are kind of housed closely together. There were a lot of COVID cases and a lot of COVID deaths in these locations. And so we're going to be asking, how did finance play a role here? To give you some more details on the facilities, I'm going to tell you about the patients, and I'm going to break down the patient mix based on who's footing the bill. So the first type of patient is a Medicare patient. They're covered by Medicare. It's a government program. About 13% of patient days are covered by Medicare. And to qualify for Medicare, you need to have a 3-day stay in an acute care setting. Essentially, you go to the hospital, maybe you have a surgery, you get treated for an injury, and then you get discharged to a skilled nursing facility. And Medicare is going to cover up to 100 days of stays. After 20, there's a copay. And these are really the high revenue clients for these skilled nursing facilities. It's about $500 per day. The next group are Medicaid. So you roll off Medicare, you need to stay longer than 100 days, you're going to be covered by Medicaid. About half of the patients are covered by Medicaid. And you can see once you roll off Medicare at 500, it drops to $220 per day. And then finally, there's private pay. So these are people that roll off Medicare, but they have the financial means to pay. And the average revenue per patient is about $275 for private pay. And a little bit on the distribution of length of stay by patient type. Here, this is the distribution for Medicare patients. They stay about 30, 35 days on average. If you're not on Medicare, they're staying longer. It's at least 100 days on average. And I'm giving you all this detail because we're going to use the patient mix as an important variable in our study. Here, essentially, the high Medicare, high revenue patients, they're going to dry up during the pandemic because all these surgeries stopped. Hospitals weren't discharging patients to these facilities. So if you were reliant on these Medicare patients, you were going to experience a large shock to your cash flows. All right, so how were nursing homes pre-pandemic? Not great. Razor thin margins, median total margin was 0 pre-pandemic. They also did not have a lot of cash on hand. They could fund about 24 days worth of expenses with the cash they had on their balance sheet going into the pandemic. And that was maybe okay for these facilities. They're kind of like utilities. They've got a very stable customer base. The government's usually footing the bill. So they didn't need a ton of liquidity until a pandemic hits. And then it would be great to have cash on hand. They were faced with a couple major shocks. One was exploding costs. So you had to pay to test your residents at least weekly. You had to have all sorts of PPE, N95 masks, surgical masks, and then labor costs also increased with hero pay. Some nursing homes that were spending $20,000 to $25,000 per year on PPE were spending close to $100,000 per month. So this was a huge shock to their cost, and having some cash on hand to help buy those masks would be especially helpful. And then they also experienced falling revenue because there were fewer people getting discharged to these facilities. Just to give you guys an idea of how revenues drop, we can look at occupancy of these facilities over time. You see it was about 90% until the pandemic, and then it drops by 15 to 20%. Okay, so there's a big drop in the occupancy at these facilities. Another way to see this is year-over-year changes in discharges to skilled nursing facilities. It looked okay in January and then dropped dramatically in the following months. In the facilities that were hit hardest, they experienced the largest drops in residency were the high Medicare share facilities. So what I'm plotting here is Medicare share on the x-axis, that's the percentage of inpatient days that are covered by Medicare, and on the y-axis is the percentage change in the number of residents between January and June 2020. So if a lot of your patients were coming from the hospital and covered by Medicare pre-pandemic, those people stopped coming. You experienced a pretty large drop in residency. And we're going to use this as a measure of the severity of the cash flow shock the facility experienced. Okay, the data is pretty remarkable in some respects. If you take Medicare and Medicaid patients, you have to fill out all sorts of paperwork for the government. There's about 20,000 raw data fields in this data set. 1,200 are well populated. And we get data on financials, but also on the patient population mix and a number of other variables. We also get COVID data from the government, which is weekly data on cases and deaths. And we're going to use cases and deaths through October 2020 for our test. And we get quality ratings where the government rates the quality of these facilities, which is nice. You don't get something like that in CompuStat, but we can see how high quality or low quality the facilities are. That's going to give us a nice control variable, and we're going to have some other data sources as well. Okay, so what we're interested in is how does a facility's financial resources, how is it related to COVID getting into a facility? And so our main regression specification is pretty straightforward. We're going to regress an indicator that's equal to 1 if at least one resident had COVID-19 by October 2020 on a few controls that come from related literature. One is going to capture the size of the facility. That's the logarithm of the total inpatient days. This is like the number of patients they're treating on a daily basis. We're going to control for the number of employees. Both of these, the more people you have in the facility, the higher the likelihood of a COVID case. Another important control variable is these quality ratings. And so the government has 4 different types of quality ratings: overall, health inspection, resident care, and staffing. And what we find is that the health inspection rating loads and matters, and so that's the one we're going to control for. We're also going to have geographic fixed effects. In most of our specifications, it's going to be at the county level. That's going to control for any geographic variation in COVID rates or mandates on mobility or any norms related to mask wearing or other things that vary at the geographic level. And our main variables of interest are going to be 1, days cash on hand. So that's how much cash you had going into the pandemic. It's like an ex-ante liquidity measure. And our hypothesis is the more cash you have on hand, the more money you're going to have to buy the PPE you need to protect your residents. And so you should have lower incidence of COVID-19. And then the other variable of interest is Medicare share, which, as I highlighted, is going to capture the severity of the cash flow shock you experience due to the pandemic. So higher Medicare share, the more negative the cash flow shock during the pandemic, and we predict worse outcomes in terms of COVID incidence. We're also going to look at counts in some specifications as well, using either negative binomial or Poisson. Okay. So let's set the groundwork here. We're going to look at baseline drivers of COVID-19. And the first thing we're going to look at is how do COVID case counts at the county level, how is that related to the incidence of COVID-19 in the facility? And unsurprisingly, the more COVID that's circulating around the local population, the higher the incidence of COVID in the facility. If we put in these county fixed effects, they explain about 37% of the variation here. So geography is very important. When we throw in controls for facility size, inpatient days, and employees, they both load individually. Together, only inpatient days loads. So the larger the facility, the more likely COVID is going to enter the facility. And then we can control for these health inspection ratings. And here we see the higher rating facilities are less likely to have a COVID case. So the higher quality facilities are better able to keep COVID out of the facility. So this is kind of our null hypothesis. And we are going to now see if financial factors also matter for the incidence of COVID-19. And to give you our main results graphically, here's a bin scatter plot with days cash on hand on the x-axis and incidence of COVID-19 on the y. And you see the facilities with greater cash on hand going into the pandemic have lower incidence of COVID. They're better able to protect their residents. Going from the 25th to the 75th percentile is about associated with a 2.5 percentage points lower incidence of COVID-19. Looking at these adverse cash flow shocks measured through Medicare share, we see the higher Medicare share facilities have higher incidence of COVID-19. So the more negatively your cash flow was affected by COVID, the less able you are to protect your residents and the higher rates of COVID. To look at the regression specifications, cash on hand and Medicare share both load are highly significant. If we include both in the regression, they both remain pretty highly statistically significant. They seem to be relatively independent effects here. So ex-ante liquidity and the adverse cash flow shock both seem to matter. If we look at total cases, similar regression specification, we're going to use negative binomial though, and we find that the facilities with more cash on hand have fewer overall cases, and the higher Medicare share facilities also have higher cases because they're more adversely affected. They can't invest in the PPE. We can do this with Poisson or inverse hyperbolic sine. We get very similar results. So it's robust to any your favorite model here. You probably have a lot of alternative stories in mind. One might be that Medicare share, or days cash on hand, is related to capabilities or patient demographics across facilities. We have a lot of data, and so we control for zip code level demographic variables, a number of variables related to the nursing home's technology, expertise, hospital relationships. I mean, we can see what kind of severity of patients they treat. None of those things affect our results. We can control for patient demographics like race, age, percent male. Those don't affect our results. So hopefully that eases some concerns on those dimensions. Another concern is that these higher Medicare share facilities might have greater patient turnover in traffic. Well, first we show that higher Medicare share facilities actually experience a larger decline in residents, which would work against us finding higher incidence of COVID-19 in these facilities. We can also use SafeGraph data to control for the number of unique visitors to each facility during the pandemic. We throw that in and our results are robust to that inclusion of that variable. We've had questions about patient density. We can calculate the number of residents per square feet. Similar results there. We also have had questions about higher Medicare share facilities. Are they actually of lower quality, and that's why they're getting higher incidence of COVID-19? But we actually observe a quality rating, and we control for that. But on observables, the higher Medicare share facilities are of higher quality on average. So it has to be on unobservable dimensions where they're of lower quality. You might be concerned about this only happening in surge states where hospitals were overwhelmed, and so they were sending patients to skilled nursing facilities. We dropped the states that experienced a surge in ICU capacity. Similar results, and our results were robust to a number of controls and specifications. One test I really want to get to here is state-level reimbursement shocks. We wanted to get some exogenous variation in cash flow. So we thought there might be still some concerns that higher Medicare share facilities are different from lower Medicare share facilities. And the exogenous variation we found is to use differences across states in Medicare reimbursement and expansion in this reimbursement during COVID. So when COVID hit, some states increased their Medicaid reimbursement for patients a decent amount, at least $20 per day, or an 8% increase. In others, it was a very marginal increase, and some didn't increase at all. And we looked to see if that expansion was related to COVID incidents. And to do that, we interacted a dummy for whether or not the facility was in a state that experienced Medicaid expansion with the Medicaid share of patients. And what we find is that if you're a facility that had the same amount of cash on hand and Medicare share and Medicaid share, but you happen to be in a state that got this Medicaid expansion and you had high Medicare share, you're much less likely to have COVID cases, or you have lower amounts of COVID cases in your facility. So this is exogenous variation at the state level that helps support cash. These cash flows really do matter for keeping COVID out. 1 minute. Okay. Probably the last test I'll talk about is related to risk mitigation, and this is getting us closer to the mechanism here. What is going on? Are they really able to invest in risk mitigation? And for this, there is data provided by the government on shortages of PPE at these facilities for surgical masks, eye protection, N95 masks. And we find that Medicare share is strongly related to shortages. So they actually do not have the PPE to protect their employees and residents. Cash on hand is related to shortages for surgical masks and eye protection. not as strong results for the other two here. And in my last 20 seconds, I'll just conclude. Firms, individuals, institutions all face really tough decisions during COVID. Weaker nursing home finances correspond to higher COVID-19 incidents. Facilities with lower cash on hand experience greater COVID incidents, and those more affected by the stoppage of surgical procedures had a greater incidence of COVID-19 and greater within facility transmission. Bottom line, firms and institutions' financial health matters for the spread of COVID-19 and stakeholder health more generally. Thank you.
Great, thank you. And the discussant is Merih Sevilir.
Well, thank you very much for asking me to discuss this interesting paper. Daniel did a great job, and just to give you a very high overview about kind of the punchline of this paper, I took 2 sentences from the paper. I wrote these sentences, maybe they are in the older version because I didn't get the most recent version. So these 2 sentences summarize it very well. Like financial constraints or financial health of a firm matters a lot, right? And not only for shareholders, bondholders, employees, but for customers. And in this case, these are the residents in a nursing home. And I guess this is more important than, this is more important than saying, you know, financial constraints matter, because here they can mean life or death, and also for the most vulnerable people in the society, because an average person is, 65 years old, and that makes it, I think, very important. And I don't know any papers, any prior work on showing, how important financial constraints could be. So I, kind of like this focus very much. And I also believe the results, because Daniel said you can come up with several explanations and you can worry about whether it is the financial resources which lead to COVID spread in a facility. I personally don't have those concerns, because the story makes a lot of sense, right? In this industry, you have capital and your job is to protect these residents. And if you don't have that capital, you can't protect them, and they either get sick or they die. So other explanations, whether the county is experiencing a high level of COVID, or Medicare share facilities are different from low medical care facilities, they are really not that of a concern for me. So I 100% buy the results, and I'm convinced by them. So my concern is that, the punchline of the paper is financial constraints matter, right? And actually they do. Financial constraints exist and they matter. And for those of us who do research in corporate finance, that's why we have a great job. And I think it is one of the most studied questions and most well-established findings that they matter. So here we are actually showing it. It matters in this specific setting for this specific segment of the population. But I would like to encourage or give a little bit suggestions to Daniel and his co-author, maybe, to add a little bit more nuance to this well-accepted finding that we have in corporate finance for hundreds of years, I would say, right? So, as I said, I really like this focus on financial constraints mattering for customers, right? But is this nursing home industry a unique setting? Probably not. So I was thinking about grocery stores, right? So if we can repeat the same story, we would probably find very similar findings. So I was in Italy, in Milan, during this pandemic when it started, and we all had to go to grocery stores, right? And there was a huge variation in how kind of they were, effective in mitigating risk, or how much variation there was across grocery stores in providing delivery to homes, right? So, I guess there are other settings where financial constraints matter for customers. So not really unique to this industry. And again, there is a nice discussion in the paper about like financial constraints being endogenous to a firm's or industry's business model, quality of management, managerial incentives, degree of asymmetric information about the firm, and etc. So I was thinking, you know, maybe an interesting direction, like an interesting additional direction, right, could be to look at, you know, who owns and manages these nursing homes, right? Because there is, right now, we don't really know about them. Are they publicly listed? Probably not, because there are like 20,000 of them, right? Are they non-profit? We don't know. Are they like private equity owned? We don't know in the current paper. So are they family owned? Again, we don't know. And maybe look at that and say something kind of new about maybe owners with more professional skills, business skills, are doing a better job in protecting their residents. And I think that can be a fascinating direction for the paper, because right now there are two papers on private equity's involvement in the nursing home industry, and they have opposite conclusions, right? The first paper says private equity is bad in the nursing home industry. They reduce the quality of care at nursing homes. There are more deaths and bad outcomes. The second paper says the opposite. They are actually good. There is more, more staff, special staff to take care of residents, and especially in areas where there is a lot of competition. So I feel like the paper is can make a fascinating contribution, right, to this unsettled debate, which is a very current debate. And I was talking to Daniel in the break, and I was suggesting, I'm sure they will give you the data, because they already know which resident homes are owned by private equity. And there are really good reasons to look at whether these effects are mitigated or they are worse when we have private equity owners. Because in my research, for example, in hospitals, what I learned is that doctors and nurses say, we don't go to medical school to get better at paperwork. We don't want to do like bill processing. We don't want to do revenue collection. We are here to treat people, so they need these business skills, right, or managerial skills to collect account receivables, to send the bills on a timely manner, and to manage working capital better. And that's the heart of the paper here, cash on hand. If you do a better job in managing your account receivables and in your account payables, then you will have higher cash in hand, right? So there's a very natural reason, I think, to look at in this direction. Plus, private equity firms, some of them at least, have really good reputation and credibility, so they might be more kind of effective in getting this capital needed from the outside world during this crisis, right? They could actually be doing a better job or worse job in attracting and retaining nurses by paying them maybe higher salaries. And as a result, we could find maybe PE-owned nursing homes are more resilient to the shock, right? Or it could be the opposite. I don't have a bias. I actually find that they are really good in hospitals, but there is another paper showing that they are really bad. So this field is really unsettled right now, but I think it can be a fascinating contribution, and maybe in another paper. Right, so that is kind of my first suggestion. The second suggestion is there is this financial constraints channel that Daniel and his co-author is pushing, right? But there is also a labor channel. He talked about it, right? If you have the financing, you can hire or retain your nurses. And to me, he showed us the results about PPE, and masks are expensive, or they got more expensive, or vaccines, these things are very costly. But to me, probably like labor, or not even the price of labor, but the availability of labor should be much more important in explaining these outcomes. A nursing home could have a lot of money, but if they can't find nurses who are willing to work there because they are concerned about their own or family's health, then residents would be in greater risk So I would like to see a little bit more discussion about that. Are we really, financial constraints are important, but is it because these nursing homes can't buy the PPE equipment? Or is it because they are not getting this like skilled, critical healthcare workers during this most critical time? And I am a little bit, not concerned, but surprised that employment is not significant in any of the regressions. Maybe we could split it into like skilled employment and not like medical field employment. But yeah, that I would like to see a little bit more on that direction. And here, like reliance on Medicare revenues is very important, because as Daniel explained to us, you get a lot of money from Medicare, right? So then nursing homes with a greater proportion of patients coming from Medicare, they experience a bigger shock, cash flow shock. But the trade-off is not that clear to me, because they are also the ones which are having very few residents. So they have less money, but they are gonna take care of a lower number of patients, plus, so that means less capital needed, plus they will need less nurses or less people with outside contact. So there is that interesting trade-off, and maybe, you know, having a greater reduction in your cash is dominating the other factor, but I would like to hear a little bit more discussion. It is not completely clear to me why, you know, Medicare share implies a greater cash flow shock, and then it would be positively related to COVID spreading. Yeah, so I think, like in the beginning of the conference, René was saying, it's like pandemic is a great opportunity for us because we learn things, right? And then maybe, you know, we can use this learning after the pandemic. So here, what I thought about is that, like, this industry seems like it is in a very poor condition. Like, you know, profit margins are very low. You know, like, they have very little cash. Outcomes, like patient outcomes are not great. Those two PE papers, they have nothing to do with COVID, but still like very bad outcomes happening in one of them. So I was thinking, again, is this really about COVID, necessarily about COVID, or regardless of COVID? This is an industry that, you know, is suffering from a poor business model. And again, one is like, they don't have business skills, right? And this could be very important because, like, you need people to run the business in addition to providing healthcare. And also, these numbers were very interesting to me. Like in the US in 2016, there were 15,600 nursing homes, but then there are a lot of other similar facilities. And when I just added them, like roughly, I found 65,000 facilities, right? So then I wanted to know, maybe some of them belong to a chain, right? They are consolidated and they have a greater ability to weather a storm, because maybe, you know, in North Carolina things are not bad, in Indiana they are very bad, and it's like internal capital market story. And the nursing home owned by a chain could do a job in allocating resources from from less badly hit places to really badly hit places. So that could be an interesting direction to see that chains would do a better job in mitigating the risk. And another thing is that, you know, maybe again, this is not about COVID or financial constraints, right? Because average book leverage in table 1 in the older version is like 76%. So this is not a financially constrained industry then, right? Because I think for S&P 500 companies, the average leverage ratio is like 30 to 40%. Of course, this is book leverage. But are we really talking about an industry which is very opaque, which is R&D intensive, innovative, and they can't borrow, right? Where is the money coming from? Is it like internally generated cash and equity, or is there a lot of bank financing? If there is a lot of bank financing, why they are having this problem? So that was not very clear to me. And overall, I have only 1 minute. I think it's a fascinating setting, and I really like this focus on this important part of the society who needs a lot of help in making decisions and in protecting their health. But given this enormous literature we have, right, on the importance and existence of financial constraints, I would like to read a little bit more than financial constraints matter. That's why I had a few suggestions. And one could be different ownership structures or organization structures, like chains versus standalone. And then what takeaway should I take away from the paper? Also, that is again not super clear to me in the version that I read. Is it that financial health and constraints matter? Is it that nursing homes need help? Is it that they should have more cash regardless, so that they will be more resilient? So maybe a little bit more clarification about what is the main kind of takeaway from the paper. But yeah, thank you very much for this opportunity again.
Thank you, Merih. Daniel, would you like to come and this one? Are there any questions? Here.
I don't know where the mic is. Oh, there it is. Sorry.
Thanks. I guess I would be particularly interested in seeing more details on why financing constraints matter in terms of, what are the mechanisms underlying that. And I think I'm also skeptical, as Merih was, that it's more than just buying PPE. So I'm wondering whether there are things like patients per room that might matter, or number of workers per patient, and also whether other funding sources may be important, such as facilities that are tied to various religious groups, or possibly government-supported facilities, whether that makes a difference, as well as whether there's nursing chains, as Merih mentioned.
Okay, should we collect all the questions first?
Sure.
Alison had a question.
So my question is about PPP. I guess that's what I'm talking about today. And I think in the current version of the paper, it's sort of addressed in like an appendix of, because it affects employment and not caseloads, that it shouldn't, interfere with the identification, which I think is true. But I'm just curious, like, if you could just comment on how you think that interacts with it, especially given what we know about the fact that PPP funds flowed to like less affected areas. So there seems to be kind of a disconnection there between where the PPP went and then how these facilities were affected. So just comment on PPP and how we should think of that fitting into this.
Right. And I think there was one question back.
Very nice paper and discussion. So a question and a comment. The question is, liquidity conditions were relatively tighter right before COVID toward the end of 2019, and then initially they worsened, but then there was a lot of injection of support and liquidity, both on the supply side for the nursing home themselves, but also for the patient, for the customer. And I wonder how you think about that, whether it could be affecting some of the results. And partially in response to the very nice discussion, there is a paper by Sabrina Owell and co-authors that looks specifically at the role of venture capital on nursing home. I think the message is very much in line with yours, and there is an attempt to trace it back to the type of ownership and specifically the type of skill that they deploy, that is not necessarily to manage this facility in the best interest of the patient, but rather exploiting the system for in extracting rents from the reimbursement system and so on and so forth.
Right. We have one more. Okay.
I was just curious to know whether you have checked other periods, so a bit on the external validity, right? So this is obviously a very particular time, also important, but that requires probably in sort of emergency measures. But I was wondering to what extent we would also have evidence from other periods and potentially other diseases and outcomes.
Go ahead.
Okay. Thanks for the great discussion. A lot of comments on the positioning or how to interpret if it's just financial constraints matter. Yeah, that's tough. I feel like almost every corporate finance paper, it's like saying the same thing. So it is a little bit hard to be unique. We do think that like the life and death aspect does make it especially important, and just understanding the pandemic in general, it's a really important setting. But we can, work on the writing there and positioning. We can potentially take it in a direction where we're looking at ownership and chains and if they're publicly traded or not. There is that data. We haven't played around with it too much. We don't have the private equity data. Maybe people are willing to share that data. I don't know. Their papers are not published yet, so we'll see. But we can ask them. That would be interesting. There actually is a paper on private equity ownership in COVID and for nursing homes, and they find that private equity ownership is this came to me after we talked, is negatively related to COVID incidents. So that's a +1 for private equity on that front. But there's all sorts of different things that we could do with ownership structure, internal capital markets, and things like that. The labor supply question is about, are they able to hire better employees during this time? Would be very interesting and maybe something we can do with updated data. Were they better able to retain like full-time employees versus part-time employees? In terms of the Medicare share and whether or not that's actually cash flow shock, our kind of underlying assumption is that revenues are dropping more than costs. These places have a lot of fixed costs, and so revenues are probably going to drop more than cost here. Maybe something we can test in the data. And then the high book leverage, I think probably a lot of it's just like the mortgage for these facilities, but that's we can dig into why they are so highly levered. A lot of great directions we can take this. So questions on the mechanisms. We have looked at patients per square foot. We haven't looked at patients per room. That doesn't affect the results, but we could look at potentially patients per room. We could look at workers per resident as well. These are all great suggestions. We might be able to see if they're related to religious groups. I don't think we found much on profit versus nonprofit, but our reading of the healthcare textbooks and everything is that profit and nonprofit are run pretty similarly, and so that might explain it. With the PPP funds, yeah, that we said related to mainly to help retain employment and not for PPE. We could potentially go and dig deeper into that data and see if the ones that got PPP loans were better off. We started down that road and then stopped, but we can get back into it. And then, yeah, we know about the Sabrina Howe paper on venture capital, and there's a bunch of competing papers in both hospitals and nursing homes and private, and like the discussion was saying, they all point in different directions. And we can tie in with that. And then In terms of other periods, maybe I'd have to talk to you more about what, like, are you talking about different periods within the COVID, like
other diseases and
other random
outside the, not even after any shock, right? Just even some correlations between leverage and outcomes for patients, I think would be, at least to me, I would be curious to
see how those are in.
see how those
Yeah, we could potentially do that. I hope we don't have another shock to study. Could be monkeypox. We'll see.
Great, thank you, Daniel.
Okay, thanks.
So our next presenter is Alessandro Rebucci from Johns Hopkins University.
Good morning, everyone, and thank you to the organizer for putting the paper on the program. The paper is with a team of colleagues at the Norges Business School. We're going to be talking about the impact on COVID on the financial fragility of hospital, in particular financial distress, as measured by a standard Z-score type of analysis. And keeping with the conversation that we just had, we'll try to explore the differential vulnerability of for-profit hospital versus the other type of hospital. We got interested in this question starting from the observation that this is the universe of US hospital in the American Hospital Survey. The share of for-profit hospitals after the after the Great Recession increased by about 3 percentage points, which is a large change relative to the historical stability of these market shares at the expense of government hospital, possibly through merger and acquisitions, but also outright merger acquisition and absorption of government facilities. Notice that Fed started to inject a lot of liquidity in 2007 and started the tightening cycle in 2016. So there seems to be something intrinsically related to finance and liquidity driving this big change. If we look at basic measure of profitability, we see, and is well known, that for-profit hospitals are more efficient in utilizing resources. However, their cash flow are also significantly more volatile in the cross-section. So they are potentially more risky. And then coming to COVID, here I'm plotting mobility data from SafeGraph to individual hospitals by quartile of the cross-section distribution over time from January 2018 through November 2020. You can see a very mild trend pre-COVID, then the sudden collapse across the distribution, and then the partial recovery. So COVID is an aggregate shock, and it's interesting to see what it does to the vulnerability of hospitals, because from an
What's on the axis?
on the axis is a normalization relative to of the data relative to the state traffic. So it does not have an interpretation. So it's a benchmark for normalcy. This traffic data need to be normalized relative to the total within the week. So it does not have an interpretation in terms of percentage change. The COVID shock is interesting because from an ex-ante perspective, we know that because of the shutdown, elective procedure and outpatient services were sharply curtailed. So that in principle is negative cash flow shock. At the same time, because hospitals were at the center of the response and absorbed much of the treatment of COVID patient, activity could also have increased, including through reimbursement, at least at some particular facilities. So we cannot really say ex-ante whether this drop in activity is a negative or a positive from a financial perspective. So what we do in this paper, as I mentioned, we look at the differential vulnerability of hospital probability of distress by hospital ownership, and we do so by using mobility data to forecast typical operational indicator that goes into the credit analysis of hospital. These data are released with a lag of about 12 to 18 months for the operational indicator, up to 2 years for the complete set of financial account, depending on the fiscal year of the hospital. So we try to fill this gap by using mobility data as predictor of the operational level of financial stability of hospital. In so doing, we can potentially consider this type of framework to calibrate policy intervention to hospital in the midst of an emergency. And to give you an idea, just the CARE Act supplied about $180 billion to the hospital sector, but other resources were folded in other parts of the US response to the crisis. What we find is that mobility data do relatively well at predicting the operational indicator. In the paper, in the current draft, we show that in sample for 2018 and 2018 and 19, we have both the actual data and the predicted one, so we can validate the procedure. And we now started to collect the 2020 data, and we see that even during COVID, when one could presume structural change in those relationships, we continue to do relatively well. Interestingly enough, overall probability of financial distress in the hospital sector does not change dramatically with a shock, but for profit hospital, it increases by about 6 percentage points relative to 2019. In the paper, there is an attempt to start to think about the real effect, as we just saw in the previous paper, and in a number of papers in the literature on possible changes in financial distress, but probably we'll have to separate the two steps of the analysis, as work on establishing causation is much more complicated than the predicting exercise that I'm going to be presenting. The paper relates to an existing literature on the financial health of hospital, which tend to focus on data set for particular states. And also, there is a lot of work on the ownership structure and the corporate governance of these institutions. And there is also a very active literature in using alternative data, in particular mobility data, to proxy activity in a number of sectors. So what I'm going to do in the rest of the presentation, I'm going to talk briefly about the data, the steps that we take to complete the analysis, and then take you through some of the results. And I will just mention for completeness what are the tentative interpretation or the conjecture for the real implication of what we find, which probably will develop in a separate paper. So as I mentioned, we use American Hospital Association annual survey. These are, we use data from 2011 to 2019. We could go further back, but we want to try to avoid the previous wave of bankruptcies and distress episodes after the Great Recession. So we start when that wave has passed. And we are going to be covering about 5,500 hospitals, which is pretty much the universe of US hospitals. As I mentioned, this data for the operational indicator get released with about 15-18 month delays. For the financial account, we are talking about 18-21 months, up to 2 years. So the idea to be able to perform this analysis well ahead of time is appealing from a monitoring perspective and potentially from a regulatory perspective. So here are some summary statistics to give you an idea how the business model differ across ownership type. You can see that for-profit hospitals are much leaner. They have many fewer full-time physicians, many fewer full-time employees, and number of beds. So they are linear facilities, both in terms of labor and capital. They have fewer equipment in terms of isolation room and high room that are proxy for sophisticated type of facilities. They tend to be not teaching facilities. A large share of them is located in rural areas. Here come one of the elements to think about when we think about the potential real implications. And interesting enough, many of them are part of a system. And as we will see, that is a characteristic that is important in shaping this probability of distress. So how do we go about this question? We take 4 steps. First of all, we apply an Altman Z-score for the 1983 version for public and private companies. And we identify hospitals that historically have been at risk of financial distress, defined as a value of the scorecard less than 1.8. We then run a logit model on these dummy variable, including the ownership type, but also the operational indicators and a bunch of other hospital characteristics. Here come the novel step. Then we forecast these operational indicators in 2020 using the mobility data. We do it with 2-3 alternative, relatively simple predicting models. And then we are going to plug in the forecasted operational indicator in the logit model. And we are going to forecast the probability of financial distress 1 year ahead. In this last step, what is important to notice is that we're going to plug in only updated operational variable. Everything else in the logit model will stay at the historically estimated level. So this is the Altman Z-score card. Is something that I believe most of you are familiar. The version that is applicable also to private corporations includes the working capital over total asset, retained earnings, EBITDA, and then a measure of leverage as book value over total equity. This is a plot. This is just the average. Of course, here the challenge is that these summary statistics are potentially misleading because the distribution can be evolving in many possible different ways. But these are the averages, the evolution over time of the financial distress by type of hospitals. And what you can see that in the case of the government hospital, we have a gradual pickup starting 2013, partly due to the fact that they turn out to lever up quite a bit. And we have a stabilization in 2014, 2015 of the decline in average distress in the sample once interest rates start to go up in 2016. This is the baseline logit model. It's split in two. So this is the first part of the results. This is the second one. And what we can see is that, of course, unconditionally there is a difference between for-profit hospital government and there is a constant in the regression. So the omitted category is the non-profit. And this difference, which we saw in the previous chart, survive even when we control for everything that we take into account. What do we take into account? These are the 5 operational characteristics which will be the object of our forecasting exercise. The difference between column 2 and column 3 is that we have also year fixed effect in column 3, so the relevant column to focus on is column 3. And what we can see, interesting enough, is that inpatient surgeries, inpatient days tend to detract to the probability of distress. While outpatient surgeries, emergency visits, and outpatient visits tend to increase the probability of distress. The way we interpret this in the paper is observing that pricing for equivalent procedures in the two settings is very different. So a knee procedure in inpatient service is charged much more, to the order of 1 or 2 times relative to the same procedure outpatient. So is a fee structure that allows better recovery of a fixed cost. This is the main interpretation. Looking at other control variables, what is important here is the system. Belonging to a system is important. In the aggregate, it tends to increase the probability of distress, but when we break down between hospital characteristics, you see that in the case of the for-profit hospital, unlike the government hospital and the non-profit hospital, it subtracts to the probability of distress. So the interpretation is that for-profit hospitals are particularly efficient to exploit and rely on economies of scope in order to maximize their profit. And the other most important operational variable that distinguish them from the other two categories of hospital is inpatient surgeries, with the interpretation that I mentioned earlier. So I have only a few minutes left, so let me tell you how we go about the matching, because it may be interesting more generally, between the hospital annual survey and the mobility data. So mobility data provider provide a list of point of services that need to be matched to addresses, but in a typical hospital facility, you have both the hospital itself, the physician offices, but you also have a coffee shop or a pharmacy. So we consider 3 types of samples. The most narrow one, in which we focus only on medical general hospital, and a broad one in which we consider all points of interest that are matched, presuming that even visit to the coffee shop or the pharmacy capture economic activity at the hospital, presumably related to their core businesses. And then an intermediate case in which we broaden to including outpatient centers and psychiatric centers. And the results are pretty much robust across these 3 samples. Here you see the same picture I showed you earlier, broken down by type of sample. And at the naked eye, when we look at the quartile, we cannot tell the difference. This is a forecasting model. We link our operation indicator to the traffic. In these 2 models, we use only cross-section information pulled in 2008, 2009. Here there is a hospital fixed effect, and here we have a dynamic model where we have both the level and the change of traffic in 2019. This is a model validation exercise where essentially we compare our logic model with alternative specifications of the logic where the actual operation indicators are replaced with the forecasted one. And when we look at pseudo R-square, we see that we do relatively well in using this predicted vulnerability. This is an example how we construct the forecasted probability. As I mentioned, the key point is that we keep the estimated parameter of the logic constant, and we replace only the observable for the operational indicator. With these, I'm pretty much done. We then have a hospital-specific probability of distress, and we can average it across hospital type. And when we look at the time evolution, we see that while the overall one for the whole sample stays relatively stable, in the case of for-profit hospitals, we see a sharp increase of almost 7 percentage points, despite the fact that previously, through 2019, we had actually seen, we had not seen an increasing trend. Let me just give you a sense of where the real effect could be going. These for-profit hospitals tend to be the largest provider of specialty care. And specialty care tends to be located in urban areas. Hospitals in rural areas tend to be general hospitals. So the risk here is that financial distress were to translate in loss of service provision in specialty care. And here specialty care we have two in particular, long-term critical facilities, which I suspect partially overlap with the type of nursing services that we heard earlier in the paper. It would increase the distance that the rural patient has to commute in order to access service. So this is the linkage that we have conjectured in the paper, but as I mentioned, the data are pretty complex to slice, and probably that will go into another paper. So let me conclude here, I'm out of time. We predict financial distress. We're proposing to use mobility data to forecast operational variable that goes into the credit risk analysis of this type of facility. We find that in the case of for-profit hospital, there is a larger increase than other type of hospitals. And because they are the main provider of specialty care, there is a possible, or there is more work to be done on better understanding possible real consequences. Thank you.
Thank you. And the discussant is Katharina Lewellen.
Thank you very much for the opportunity to discuss this paper. So as Alessandro summarized very well, the paper basically examines financial distress of U.S. hospitals particularly during the 2020 pandemic. The broader motivation, at least the way I read the paper, is twofold. So one is more kind of methodological one, which is to develop a way to estimate probability of financial distress for a hospital using real-time data, right? So we have high-frequency data, and we can get the information quickly, if we need to potentially intervene. The second, at least the way kind of the paper reads, is to kind of understand the effect of the ownership status, so for-profit or non-profit, on the probability of financial distress. The main findings that the for-profit hospitals do appear to be more fragile, more vulnerable to these types of shocks. Probability of financial distress for the for-profits is 7 percentage points higher based on their estimates during 2020 than other hospitals. And the conclusion that they kind of draw from is that there may be a need to kind of reevaluate the provision of healthcare, particularly in these areas such as specialty rural, which are dominated by for-profits. So first, I just wanted to kind of say a few words about the motivation and the big picture. So both of these goals that I have here, I think are very much worth pursuing, possibly even as two different projects. And I was very happy to learn from Alessandro that that's exactly where they want to go. They want to split into projects, because at the moment I felt like they were a little bit kind of intertwined to me. So the way I see it is that there is project one, which is simply kind of a practical goal to develop a procedure that can be used to identify these vulnerable hospitals, pinpoint which might be in trouble so that when we can potentially intervene if needed. Second is more kind of understand the economics behind it. So that goes into, really better understand the way these hospitals make financing decisions, corporate decisions, including how these decisions are affected by their ownership status. So at the moment, the paper is kind of trying to do both, and I think that the methodology that you are using is really much better suited for the project 1 than for project 2, and I would focus the discussion in the paper on that as well. So that is my first point. The remaining comments. So I'll say some things about the methodology, predicting hospital financial distress. Then I'll talk about this result, which is the financial fragility of for-profit hospitals being larger, the findings, the implications, and I will say a few words about hospitals during the COVID crisis and what I kind of draw from this as implications for the paper. All right, so predicting hospitals' distress. So what they do is they take the Altman Z-score model, estimates from an Altman paper, plug in the financial variables for the hospitals, get a Z-score for every hospital, create a variable 0, 1. 1 if Z-score is above a certain threshold. That's what they are calling now financially distressed. All right, so that's step 1, and now where the innovation comes in is incorporating the real-time data from the cell phone traffic into this methodology. So how do they do it? So first, they run essentially this logic model here, where they take that 0, 1 from Altman and regress on operational variables that describe kind of the hospital's activity, outpatient visit, emergency visit, inpatient visits, and so on, and other variables. So that is based on a panel prior to 2020. Then, as the next step, they take each of these operational variables and regress it on cell phone traffic, also prior to 2020. And then essentially take these beta coefficients from the logit, as well as the gamma coefficients from these linear regressions, combined with the cell phone traffic from 2020 here to get essentially an estimate of the likelihood of financial distress for these hospitals during 2020. All right, so let me just a few comments on that. So first, the Altman model. So I'm going to have to complain a little bit about using, these coefficients from the Altman model that are based on private firms that are not hospitals. And there is actually, there are good reasons to expect that these coefficients might be different for hospitals, number 1, as well as for-profit versus non-profit, differences in business, financing, accounting, and so on. So for example, for equity, I wouldn't even know what equity is for a non-for-profit. So if you mean maybe endowments, they are probably treated in bankruptcy differently, so I bet the coefficients are going to be quite different as well. So there was, and I think that you could potentially modify this model using actual hospital closures prior to 2020, and I will show you some data that may speak to that. The second part of the estimation, so here I just want to say I was a little bit confused how it all works, so here it's just maybe asking for more clarification here in the paper. So for example, all the explanatory variables, the key explanatory variables in the bottom equation, they are all driven by one factor, which is the cell phone traffic. So, everyone has this one lever. So I'm not sure, it seems somewhat problematic. Maybe specify the conditions in which, under which the beta coefficients can be used from the top equation can be used appropriately in the bottom equations and so on. I would like to see how the model performs out of sample in 2020 in predicting distress. Maybe test it against alternative models using alternative data and so on. All right, so let's move on to this second goal of the paper, which is to understand better kind of the fragility, of for-profit hospitals, or the effects of the ownership status on financial fragility. So what they do here is, again, they run this logic model where they regress financial distress on a for-profit dummy and a number of controls. And the key findings is that for-profit hospitals are indeed more fragile. The way they interpret it in the paper is by saying, for-profit hospitals, they perhaps don't internalize the effects of their choices on the community, of the broader community. They tend to maybe make more risky decisions, have more risky capital structures, and as a result, potentially get into financial distress too much, close too early, and so on. And of course, there's a concern that these closures pose a threat to service provision, particularly in these specific areas where for-profits are more common, and there's potentially a need to intervene there in this area. So, of course, the regression doesn't tell us why for-profits are more financially distressed, and doesn't even tell us whether it is the ownership status that actually makes them be more financially distressed. So some alternatives to consider for the mechanism, they may just simply operate in different businesses. So it's not really the ownership status, it's just their choice or what kind of business they kind of are drawn to. They may be better governed and may be actually more willing to sell assets when there is negative NPV. They may be financially constrained because they don't have access to donors, they have less access to subsidies, and so on. So obviously these scenarios will have very different implications for whether and how to intervene to prevent distress or during distress. So some data that I happened to have on actual closures of hospitals. So I thought I'm going to show you this because it's kind of related. So on the left, these are actual hospital closures during the panel of between 2000 and 2018. And what you see is that indeed, for-profit hospitals who use actual data on closures, they do tend to close more often, particularly on the left when their performance is poor. And I measure performance here as just profitability, and they also tend to be acquired by systems more often than non-for-profit. So, this is certainly consistent with all these other channels like better governance, financing constraints, as well as less attention to social objectives. All right. So the last thing I wanted to talk about, since this is a conference on COVID, I wanted to say a few words about how hospitals did during the crisis. So as you know, as Alessandro already mentioned, hospitals have suffered quite a bit. Based on the AHA survey, the drop in patient volume was 19% in the spring of 2020. So this is inpatient volume, and 35% the outpatient volume, because people are canceling elective procedures, preventive care, emergency visits dropped as well. Hospitals were exposed to higher costs, sicker patients, and so on and so on. So, the government stepped in, and as part of CARES Act, there was this provider relief fund that was established, and by December 2021, there were 134 billion that were channeled to hospitals in various ways. Big chunk of this, the 57% of it, went in as part of these kind of general grants, and this program, or this intervention was actually subjected to quite a bit of criticism, because people were saying that the larger hospitals were getting more help than the small hospitals that were actually in need. The reason was that the grants were linked as explicitly to just revenue, to scale, and larger hospitals tend to be also the more profitable ones, the ones that have more private patients, and so on. So you read, headlines in Washington Post, such as some of America's wealthiest hospital systems ended up even richer thanks to federal bailouts, right? So why I'm talking about this in my last minute of my talk? So I was thinking, in that context, it would be perhaps nice to think about this analysis or a way to expand or modify this analysis to help kind of inform and fine-tune these types of allocation rules, right? So, but then you would have to kind of step back and ask our more general questions, such as, what's the objective of the rule? What are the desirable feature of this type of a rule? Simple, transparent would be nice, easy to implement, target the right hospitals. And then the issues to consider for the paper would be, is the financial distress the right left-hand side variable to even focus on? Perhaps yes, if those are the hospitals that are going to undersupply care, for example. Maybe for the sake of simplicity, maybe you would want to break up the task to identify hospitals that are financially vulnerable going into the crisis or right before, and then hospitals that are most severely affected by the crisis, right? Because those that you want to support probably are on the intersection of these two groups somehow, and maybe breaking it up that way would make it more transparent and easier to use. For two, use potentially other real-time data that will be crisis specific. So this procedures template is kind of applicable also in future crises, such as local infection rates, whatever this infection might be, high frequency utilization data, by type of service, which is available from firms that provide kind of back office services to hospitals and so on. All right, so I'm done here. Just to conclude, very interesting paper on a very timely topic. Clarify, revise potentially the methodology of predicting distress. Focus the paper really on the task of predicting rather than explaining and speculating about reasons and causality. And think potentially about the usefulness of this model in determining subsidies in future crises. Thank you very much.
Thank you. So let's take questions from the audience. Paola.
Yeah, thank you. Yes, I think it's a great project and great discussion as well. I'm actually wondering about, and I think you did it in subsequent slide, but the first slide that you showed to us in terms of the correlation between probability of financial distress and type of services, pulled all the type of hospital together. And then in the subsequent slide, you showed that indeed, the effect was very different. It was very heterogeneous for type of hospital. So my main comment here is there is way more heterogeneity in this data that you are currently not exploiting, which I think would make it much richer, especially if you're going for the two-project plan. And specifically, here is a couple of things that are important. One is the suspension of type of procedures change enormously across the country. I had some friends who are doctors in Dallas. They continue to do all the services, including elective staff, for much of the pandemic, versus you have some states completely, like think about New York, that completely shut down any preventive medicine and so on. And we know that the hospital make, at least some type of hospital make a lot of money with mammogram versus ultrasounds and so on. And so that, exploiting that would give you such richness that I think it would be a waste not to do that. So that's my main comment.
Thanks. It seems, following up on the discussant's point about federal subsidies, I think I would also be worried about whether some states were offering subsidies to hospitals around the pandemic period as well. which could also impact some of your statistics. And I'm also wondering whether you could distinguish different types of public institutions in terms of small hospital chains, large hospital chains, which again may have a lot of bearing on the outcomes in terms of insolvencies.
On the mobile data, can you actually break it down into things like, do they stay overnight? Or do they, at what time do they visit? So you'd expect emergency visits to be out of hours and things like this. So I'm wondering whether you can get better kind of predictive stuff if you have more granular data on the mobile stuff.
I think Daniel has a question.
So for the purely like predictive exercise, have you thought about using machine learning models or something that might give you even stronger predictive power? And the other thing is you're predicting like emergency visits and outpatient visits using this mobility data that you estimate that relationship pre-pandemic, but is there a reason to expect that those relationships to be constant or to potentially change during the pandemic when the types of services being done has changed dramatically?
I think we should let you
Yes.
respond.
So let me thank Katharina, first of all, for the very nice discussion and comment. There are not only two, but there are actually three papers or three contributions. I was acknowledging that thinking about the real effect is out of the question here. You're suggesting to further split. There is no identification. You were very kind, you didn't mention it, but we are fully aware, and so further toning down any suggestion of causation is warranted. And of course, if it's not clear enough that we are not claiming it, we should go further. From the annual hospital survey, you can find equivalent to those variables that need to go in the Altman Z-score, but that's of course another limitation. Is not designed for hospital, and the government and the for-profit hospital, they may really not fit there. So that's something to think about. So that covers the mechanism. The data on closures are very interesting. I look forward to talking to those pictures were amazing. But in general, I agree with your suggestion. Maybe only on the steps. It's pretty clear what we are doing. The assumption in the background here, these mobility data are a factor. So statistically, it's plausible to have a large cross section that is loading onto a factor. Here the assumption is very strong, it's one factor. We could do by exploiting different type of mobility data, having more than one factor, but when in earlier work we did it, we didn't find big difference. So we went for simplicity. One thing that can be done here, you can estimate everything jointly in a better standard error rather than layering for transparency and clarity. But the logic is simple. Of course, machine learning and AI would be a way to further lever up the technology and trying to get something statistically even more persuasive. Very good idea about the heterogeneity of, I have another paper on that, on the fact that stay-home orders and all sort of non-pharmaceutical intervention were even county-based. So that's actually, I had not thought about, is very good. State versus federal, we have not looked into that. We could. I think it's already difficult to trace federal aid, which is first order magnitude, but we can do it. Public, small versus large, we could look at size by assets or by revenue or by patients. That's easily done. We do control for the system dummy, so whether hospitals are part of a system or not, which seems to be pretty important, at least in terms of association. Statistically, I think it came up earlier in the previous paper as well. On the mobility data, yes, there are different types of this data, you can in principle distinguish a short visit from a longer one. It was not giving us strong differences in the signal, so we did it at the very early on. But in principle, yes, you have different kind of mobility data. These providers were much more generous at the beginning. I think now it's much more difficult to get this data. Going forward, they will cost a lot of money. And then on the stability and the out-of-sample validation, yes, they are stable. So surprisingly, the relationship between traffic and operation indicators stays stable. I didn't want to add the new result that Katharina didn't have a chance to see in advance, but that is the case. And similarly, we got good validation. So not the sample is not fully complete, but for the 5,000 hospitals for which we have data, we can forecast pretty well out of sample. We'll do it again, put it in the paper once we have fully updated the data. Thank you. This was very constructive. So hopefully you will see 3 papers circulating at some point.
Okay.
Sure, 2, 3, maybe 2.
Thank you. That concludes the session. I will hand over to the organizers. I think we are ready for lunch.